Hello, let's talk about cerebrovascular disease, and we'll begin with a discussion of strokes. There are two types of strokes, ischemic strokes and hemorrhagic strokes. And this distinction is very important because the way that we treat these two families of strokes could not be any more different. In a hemorrhagic stroke, there's a bleed in the brain, an active bleed due to a rupture of a small artery or a capillary bed. And in the setting of an acute brain bleed, we need to coagulate that patient. We need to clot them up. Now, this could not be any more different than how we handle ischemic strokes, which are most commonly due to thromboemboli, blood clots. So in a patient who's got a blood clot in the brain obstructing arterial supply to a region of the brain, the last thing we would give that patient is a procoagulant. In fact, we would want them on fibrinolytics to bust up that clot. And in the setting of a fat embolism, perhaps the patient's got some atherosclerosis in the common carotid artery. You could have a plaque break off and embolize into a particular cerebral artery. Then you've got to go in and do a percutaneous sort of intervention and break apart that embolus mechanically. So again, the treatment for that obstruction could not be any more different than the treatment we're going to give for a hemorrhagic stroke in which we need to clot the patient up. So that's why you want to keep ischemic versus hemorrhagic stroke separate in your head. You want to understand what's going on to cause brain death in both of these pathophysiologies, because when you get a CT scan, head CT non-contrast, you will usually be able to tell an ischemic versus a hemorrhagic stroke based on the density and the involvement and as well as the borders of the involved tissue. So some quick definitions. Ischemia is a decrease in arterial perfusion of a tissue. So when your arterial blood supply goes down, tissue oxygenation goes down. And in fact, tissue ischemia, which is a blood flow problem, is the most common cause of tissue hypoxia. Tissue hypoxia in the brain is particularly lethal because the brain neurons do not store that much glycogen. They do not store glucose. Therefore, if you deprive neurons of the oxygen that they need to accept electrons at the end of oxidative phosphorylation, remember you take diatomic O2 and turn it into water, H2O, and then you send the protons through this proton ATPase on your inner mitochondrial membrane and you kick out some ATP. So if you don't have oxygen, you can't do that. Now in the brain, where you are incapable of switching over to anaerobic glycolysis, any cell that's deprived of oxygen will die pretty quickly. In conclusion for this section, ischemia is a drop in arterial blood supply, and this is most commonly due to an obstruction, which could be a thrombus or an embolism or a thromboembolism, could be an acute vasospasm, and then another cause of a tissue ischemia could be maybe you just don't have enough blood volume to perfuse all the tissues of your body. And so cardiogenic shock, heart failure, hypovolemic shock, trauma, MVA, septic shock, bacterial infection, any type of shock, hypotension, low blood pressure can also cause cerebral ischemia, which one more time is simply a decrease in arterial perfusion of the brain leading to tissue hypoxia. So the next thing that I'll say is that ischemia is different from an infarction. Here are two examples of brain infarctions. The chief difference is that in an infarction, tissue is irreversibly dead. Can't come back, never recover. And ischemia is reversible in the early stages. So maybe if you bust the clot quickly enough, you can reperfuse an area of brain and save some of the cells there. But if the ischemia persists for too long, it will become an infarction. Here's a pale infarction on the left-hand image and a red infarction on the right side of the screen. Now, the mechanisms for these two infarctions nearly one-to-one correlate with the mechanism of the stroke itself. So ischemic strokes, in which there's an obstruction of arterial blood flow to the brain, or there's systemic hypotension, those ischemic strokes tend to lead to pale infarctions. Whereas hemorrhagic strokes, in which there's a hole in one of the arteries in the brain, those obviously tend to lead to red infarctions. So right now, I'd like to start trying to sort out how they ask these questions. They love to, first of all, show you photos of the brain, the gross brain, and they love to give you a pale infarction or a red infarction. And then what they like to ask next is the mechanism or the pathophysiology behind the infarction, to just make sure that you know that the pale infarction is correlated with ischemia and the hemorrhagic with hemorrhages. So the pale infarction is always an obstruction of sorts. And so what they like to ask is maybe what's the biggest risk factor that this patient faced, predisposed this patient to this pattern of brain death. And then they show you a photo of a pale infarction, and you have to say something like atrial fibrillation, because that breaks off clots from the wall of the left side of your heart, puts them into circulation, they go to your brain, they obstruct. Also atherosclerosis, maybe it's like a history of hyperlipidemia, you know? So that's how they ask these questions. They give you a patient who got a clot or an embolus, and then they say what predisposed the patient to this pathology. Same thing with the hemorrhagic stroke, the red infarction. Only difference there is that our big risk factor for that is going to be hypertension. And there's nearly a whole page on risk factors, specifically modifiable risk factors here. So one more time, they love to give you a patient who's got, you know, maybe they have atherosclerosis and a family history of coronary artery disease, and then they say patient suffered a stroke. What would you likely see on autopsy? And it would be like pale infarction, something like that. Or what was the mechanism of this patient's stroke? And so then A would be like thrombus on the wall of the blank artery, and then B would be like embolus occluding the blank artery. So you have to know the fine differences in between a thrombus and an embolus, you know, all these different pathologic terms. Probably the last thing that I really want to hammer home about this is that you see a red infarction, a hemorrhagic stroke, 9 times out of 10, the mechanism for that is that the patient's had hypertension, because what's going on? The wall of a blood vessel is popped. How do you pop a water balloon? You fill it with too much water, and then it'll eventually pop. And so hypertension, your blood pressure is very high. There's too much water in the water balloon. You eventually reach an area of weak circulation, or maybe it's of thin-walled arteries in your lenticular striate arteries, for example. And a blood pressure of 190, 200 systolic, that can begin to pop arteries. Versus the pale infarction, the risk factor for this always going to be involved with something like atrial fibrillation, in which again you get clots going into your arterial circulation. And then CVD, coronary vascular disease, coronary artery disease, however you want to say it, atherosclerosis, that's what we're talking about. Because what is atherosclerosis? It's fatty plaques lining the inside of the bloodstream, and the force of blood flow through a bloodstream can knock off a plaque and embolize it to where it occludes, for, in this example, the anterior cerebral artery. And so there's always an occlusive pathology here. Don't forget, shock, hypotension can also be a cause of pale infarction, but they always give you that in the question stem too. You know, they'll tell you patient is 90/60 or something like that. So pale infarctions, occlusive in nature, ischemic tissue damage, hemorrhagic infarction, hypertension is the big risk factor there. And the treatment for these two separate types of stroke are very, very different from one another. So that's about all I got to say about strokes. And the rest of this SDL is about various forms of brain ischemia. And then the second SDL talks about hypertensive and hemorrhagic strokes. One thing I highlighted was fibromuscular dysplasia. You want to understand that there is a problem with the tunica media of the blood vessel inside a patient with fibromuscular dysplasia. And so the way that I'll explain that is that any large or medium artery has 3 layers to it. It's got an inside, which we call the tunica intima. It's got a middle, which is comprised of smooth muscle, and we call that the tunica media. And then it's got an outside, outermost connective tissue coating, and we're going to call that the tunica adventitia. And so when we say that there is medial hypertrophy in a patient with fibromuscular dysplasia, what we mean is that this middle smooth muscle cell layer has grown in number, it's proliferated, it's hyperplastic. And so that's going to cause stress on the walls of an artery for a patient with FMD and render it more prone to rupture. So FMD, how do they ask this? How do they present this patient? They'll typically give you a patient who is usually going to be a young woman, and you'll auscultate maybe a kidney bruit, and a bruit is just an area of high flow, and the blood flow through this artery in the case of a bruit is so fast, it's so loud, it's so turbulent that you can hear it with a stethoscope. You can hear turbulent flow. All right, let's take a little bit of a detour. You hear bruit, anytime you hear that, what that means is there's turbulent flow. So laminar flow is like silent. It's quiet. It's like you're trying to get out of the house and you're not trying to wake your parents. That's how quiet it is. Turbulent flow is like, all right, it's 4 a.m. Like I'm opening the fridge, I'm microwaving something, like I'm kicking something over, and then the dogs start barking, and then everyone in the house is up, and it's like, oh, great. So, turbulent flow is loud. And so when the question stem tells you there's a patient with a bruit, that means there's turbulent flow. Now, what causes turbulent flow? And it's like, okay, disruptions, bumpiness on the inside of the vasculature. So like in a heart valve, if there's a valve problem, that creates turbulent flow. You can hear that turbulent flow. That's why you have heart murmurs when patients have valve problems, and you don't have heart murmurs when they don't, because there's really not that much turbulent flow. So moral of the story, you can hear turbulent flow. Back to FMD, this patient's got a bruit because, again, they've got this fibromuscular dysplasia in which the tunica media is involved. And so if you were to do an angiogram on a patient with FMD, you would see beads on a string, which is the classic angiographic finding here. And again, that once you see this, there's a problem with the tunica media of this patient's blood vessels, and it's going to predispose patients to aneurysms or outpouchings of the wall of an artery, and it's going to predispose them to hemorrhage in any affected organs. And so the kidneys, as you can see here, are commonly affected, and so is the brain. And so you can get a hemorrhagic stroke if you're a patient with FMD. And their blood pressure is typically very high. That has to do with the renin-angiotensin aldosterone system. Usually they just ask you to make the diagnosis, and sometimes they'll ask you, what do you see on histology? And again, that would be that medial hyperplasia. So the reason I bring that all up is because it's here in the SDL, and I would say it's the most buzzwordy or testable sort of condition laid out in these first few pages here that's not totally obvious. We start to talk about pathology of the brain in this SDL. First, it talks about gross changes, and then it talks about histologic changes. And so I would say recognize both timelines. I think that the histology is probably a little bit more important to hammer home, because the gross changes are kind of easy. You're not going to see any changes very, very early on, but eventually you get some dusky gray discoloration, which is kind of your middle stage. And it's the brain. It can't really do much other than dusky gray discoloration. There's not a lot there but neurons. And so it'll eventually undergo liquefactive necrosis precisely because it lacks largely in architecture. It doesn't really have rigid supportive cells, right? So it undergoes liquefactive necrosis. I think that's the real take home here, is that because you don't have a big time mesodermal component to hold things together in the brain, you will see liquefactive necrosis. And it's the only spot in the body where this is normal or physiologic. You see it anywhere else and there's abscess, neutrophil problem, right? That's the only other way I can think of. You get a liquefactive necrosis. And then going to the histology of brain tissue death, first aid lays this out pretty well. wherein there's this timeline, this progression, and get used to it because you'll see this again in the heart, where they want you to recognize different histologic findings at various points of time following an acute myocardial infarction. So you'll see this exact pattern of information again. And the question is really simple. It's just, here's patient, they had a stroke. You are looking at the brain. 4 days later, what do you see? And the answer in that case would be, oh, well, I see microglia all over the place, right? So that's it. It's a really simple question. You just have to learn the timeline. And what they really like to ask about is this 12 to 24 hour period where you do see red neurons. You don't see any other change before the 1 day mark is out. Once you do, you start seeing neutrophils, which are indicative of acute inflammation. And understand that the word inflammation, what that means is immune cells are doing something, and that's what causes inflammation, because inflammation is a cytokine-driven process. And so immune cells react to cytokines always, always, always. And so inflammation is parallel, hand in hand. You can't have inflammation without the immune system. So then that acute inflammation starts to kind of peak and then die down. And that's when you get your macrophages in there, and then they'll undergo the M1 to M2 transition. Once you get M2 macrophages in the game, that's when you start trying to scar up that tissue in any way that you can. But then again, recall that the brain is not that good at scarring because it doesn't have fibroblasts, doesn't have smooth myocytes, but it does have astrocytes. And so they will scar as best as they can. That'll be called a reactive gliosis because astrocytes are glial cells. And then we refer to the scar that you see about 2 weeks and farther out after a stroke as a glial scar. Something else from this page of first aid that you really want to take away, because I've seen questions asked on this topic before, is what sections of the brain are most prone to ischemic injury? And in order, they are: number one, the hippocampus, which is a structure particularly involved in memory formation. And then number two, the neocortex, neo meaning new, and we call it the new cortex because it's the most recently evolved part of the cortex. So when we say the cortex, we're talking about the outermost layer. And so you want to understand the word cortex because the kidneys have a cortex, and it's the most superficial layer of the kidneys. The adrenal glands have a cortex, and it is the most superficial layer of the adrenals. And so the brain has a cortex. It is the most superficial and hence the most recently evolved part of the brain. And so within your cortex, you've got 6 histologic layers of cells. You understand that. And so cell layer 3 is particularly vulnerable to neuronal death. That's what they really want to ask you about if they ask you about brain death in the neocortex. And then the cerebellum finally is also particularly vulnerable to ischemic injury because Purkinje cells, which are the GABAergic output cells of the cerebellum, remember that they output via the superior cerebral peduncle to the contralateral brain. And those cells are large and they have a high oxygen demand because they are so large. And so any cell with a high oxygen demand, hypoxia, ischemia, will hit that cell first compared to a cell that can go a little bit longer with low oxygen supply. And then watershed areas, we'll get to that too. What I want you to take away for now is that the hippocampus is the answer. If they say what cell type dies first or what structure dies first in the brain, it's the hippocampus. And if that's not an answer choice, then you're going with neocortex, specifically layers, I think 3, 5, and 6. So I've seen that across different question banks. This is a very common topic to ask about is what's the progression, what's the stepwise order of events going on in brain ischemia. We talk about transient ischemic attack, TIA. This is something you want to know what that is. It's essentially a hypoperfusion of the brain that goes away and it corrects itself. And so this can happen with a blood clot. Understand that your body has a fibrinolytic system that cuts apart blood clots and remodels them and maintains hemostasis, a balance of clotting and not clotting inside the bloodstream. So if you inappropriately clot, then the hemostatic system that's in your bloodstream is going to chop up that clot and get it out of there. So if you have a clot, then your part of your brain is going to be ischemic. But then if you get that clot out of there, the ischemia goes away and you reperfuse the brain. Hence why this is called a transient ischemic attack. And remember, ischemia is not infarction. Ischemia is reversible in the acute stages. Infarction is irreversible. You're not getting that tissue back. And so a transient ischemic attack, often patients have only a slight little drop in functionality because again, they're going to have a little cell death, but most of those cells are going to be able to come back to life once you reperfuse the brain. Patient who has had a TIA is at risk for another one. About 1/3 of patients with TIAs will experience a stroke within 5 years of their TIA. But again, 2/3 don't. So sometimes this is just a happens type of thing. And it can also be due to not just clots, but hypoperfusion, maybe if someone faints, and their blood pressure goes very low very quickly, that can cause a little transient ischemia to the brain that is, again, rectifiable by the return of perfusion to that tissue. So that's TIAs. You want to recognize that. Again, symptoms in a TIA, you don't have very many symptoms, actually. It's minimal symptoms, but the patient will always report that this occurred for a certain amount of time and then it self-resolves. So that's what clues you into thinking TIA. Now let's discuss subclavian steal syndrome. This is in the setting of atherosclerosis in a particular place within the lumen of the subclavian artery. Let's look at a photo of subclavian steal. You get atherosclerosis. So first, your right brachiocephalic artery branches off your aorta, then your left common carotid, that will be right here in green, and then finally your subclavian artery is going to branch off, and your vertebral artery branches off your subclavian. And so if you have atherosclerosis in the most proximal portion of the subclavian artery, then you're going to have a tough time pushing blood from the aorta into the subclavian. Now, when this happens, the subclavian artery downstream from the obstruction becomes a very low pressure zone. So I'll try to illustrate that right here. And when this subclavian artery becomes a low pressure zone, because again, it's not got a lot of blood in it, you understand that in the life sciences, physical substances diffuse from areas of high concentration to low concentration. That's a basic principle. And so blood is going to sprint from the vertebral artery where it's pretty high pressure up here. You've got the circle of Willis, you've got the arterial supply from the contralateral vertebral artery, blood's moving up that one. And so blood's going to then go down the affected side vertebral artery and into the subclavian vein artery that is a low pressure zone. And so when this happens, the subclavian artery is literally stealing blood from the brain, from the vertebral artery. And again, that blood is getting to the brain from the contralateral vertebral artery, which is not obstructed, which does not have atherosclerosis. So you want to understand the underlying cause of this is atherosclerosis, and that the patient is going to get really lightheaded, especially when they perform any motions with their shoulder that would further occlude or obstruct this atherosclerotic subclavian segment. So here's a question that has subclavian steal basically is the answer choice. An 80-year-old man reports that he passes out. This only occurs when he tilts his head back. He has a 50-pack year history, well-controlled diabetes and hypertension. Pause. Diabetes is an equivalent risk factor for coronary artery disease, for atherosclerosis. What that means is that if a patient has diabetes, we treat them clinically as if they have atherosclerosis. Even if they don't, we manage them and we set goals for them and we do risk stratification for them as if they have atherosclerosis. That's how bad of an endothelial disease uncontrolled diabetes is. So when they tell you a patient has diabetes, they are telling you, hey, this patient, treat them as if they already have atherosclerosis. So back to the question. Guy has a history of a left carotid endarterectomy as well as a surgical repair of a AAA. This is further confirming, hey, this patient has atherosclerosis. You can treat this patient as though they have fatty plaques everywhere. So then you, the doctor, inform the patient he is likely experiencing transient brainstem ischemia when he extends his neck. Occlusion of which of the following vessels would produce these symptoms? So the brainstem, what arteries go to the brainstem? You need to know that to answer this question. That's going to be right your ICA, anterior inferior cerebellar, and your PICA, posterior inferior cerebellar. And then your vertebrobasilar system also supplies the brainstem. And so one more time, let's go back to this image and see that you're stealing blood in the setting of subclavian steal. You're taking blood away from the vertebrobasilar system that turns into the ICA and the PICA. So that is why you see transient brainstem symptoms such as passing out. Your brainstem controls consciousness. Your brainstem controls respirations, you know? So you're going to see brainstem symptoms in the setting of a patient with subclavian steal. And again, the question is asking, what's the mechanism of these symptoms? And it's atherosclerosis of the subclavian arteries, because that's going to pull blood away from the arteries that supply the brainstem. And we go through the other answers. And anterior spinal, you know, it's like, no, I mean, because that wouldn't take any blood away from the vertebral. External and internal carotid, no, because then that would be a lot worse than that. You'd have a little bit more symptoms going on, I would think. Subclavian arteries, again, you know what subclavian steal is. This fits the profile perfectly. So that's a pretty important topic. Here's another one, the lacunar infarction. Let's look at some lacunar infarcts. Notice on this CT scan, it's a little hypodense area reflecting tissue death. Hence the word infarction. And infarction is tissue death. Ischemia is reversible, but once it becomes infarction, done deal, the tissue is dead. So you see tissue death on this CT, and it's in a particular region. It's kind of in the middle of the brain, in the center of the skull, right next to the ventricles. And what that's going to tell you is that these are perforating arteries that usually supply the basal ganglia and the thalamus. These are not cortical arteries, so you don't see cortical symptoms with a lacunar infarction. You see usually pure motor symptoms typical of a basal ganglia stroke. So that's how lacunar infarctions present, with pure motor symptoms that are typically unilateral because the basal ganglia are affected. And anytime you see pure motor, basal ganglia and cerebellum are very high up on your list. So this is, again, where a lacunar infarction will be on CT. And the next important point I have to make is that this is, as a concept, very similar to the Charcot-Bouchard microaneurysm, but this is not the same thing. A lacunar infarction has an ischemic mechanism. So an embolus, a thromboembolism, a blood clot, you know, an atherosclerotic plaque, those things could give you a lacunar infarction. But rupture of a lenticulostriate artery in the setting of exaggerated hypertension, maybe in a patient who is not controlling their salt and fluid intake, or in a patient with a 50-pack year smoking history, that is going to lead to a little bit different presentation called a Charcot-Bouchard microaneurysm. And this is how those like to present. Similar location, right? Kind of in the basal ganglia area. You can tell that you're sitting here, are your lateral ventricles. There's 1 and 2 right there. And so you can see you're just outside of them. And so you know that the things like the putamen sit right there in that little groove. So it's a stroke in the basal ganglia, and it's either going to be hyperdense or hypodense, right? And so you always get a contrast CT. You see something in that area. Your differential is lacunar infarct versus Charcot microaneurysm. Let's go ahead and look at questions about this, and then let's talk about it conceptually. This is something that's kind of tough to break down. Here's a 65-year-old woman with a 2-hour history of headache, vomiting, and right-sided weakness. She has a history of poor compliance with her medications, which do include a couple of blood pressure agents. She's got slurred speech and decreased strength in the right and lower upper extremities. So unilateral motor symptoms. Sensation of light touch is also decreased. You got some plantar reflexes against some motor neuron signs. Blood pressure is 190/110. You order a non-contrast CT like you always do, and you see a stroke in the basal ganglia. So then what's the question? What's most likely responsible for this patient's condition? Here's what I want you to take away. Notice how Charcot-Bouchard hemorrhage and lenticulostriate artery thrombosis, they're both answer choices. Now, the lenticulostriate arteries are affected in both the lacunar infarct and the Charcot-Bouchard aneurysm, but the mechanism is what sets them apart. One of them is a hemorrhage. The other one is an occlusion leading to an ischemic stroke rather than a hemorrhagic stroke, leading to a pale infarct rather than a red infarct. Got to be able to tell these two things apart. We look at the other answer choices. What's responsible for the patient's condition? Something like amyloid angiopathy. No, that would present more diffusely, I would think, as compared to a very focal hemorrhage. AVM, arteriovenous malformation. No, typically those, if one of those ruptured, it'd be a lot bigger. They don't like to be inside the midbrain. They like to be in the cortical areas is what I'm thinking with an AVM. They like to be farther out towards the cortex, and probably would have noticed an AVM later or earlier in life, because they don't just kind of spontaneously happen. To catch an AVM in someone's sixth decade would be very rare, I would think. Invasive growth, no, this is not a well circumscribed mass. It's got a funky border to it. It's a very different density than the surrounding tissue. So I can assume that this is not a solid mass. Over anticoagulation, well, that could be a predisposing factor in her bleed, because then she would bleed and she wouldn't be able to coagulate it. But that's not going to be what's directly caused. That's not the underlying cause of the bleed. You could be over anticoagulated. You're still not going to bleed if your blood pressure is 120/80, you dig? Because there won't be any endothelial damage. And so then rupture of berry aneurysm, why is that not the correct answer? Well, wrong location. You'd be subarachnoid for that. You'd be like right anterior to the brainstem. And this is clearly higher up at the level of the lateral ventricles in the fornix. And so you can cross that off the list. Again, one more time, you're back down to Charcot hemorrhage and lenticulostriate thrombosis. E right there is a synonym for lacunar infarct. So I'm telling you, you could get both of these as answer choices in one question, and you got to be able to pick the hemorrhage apart from the infarction or obstruction. How do you do that? It's all in the risk factors. If the patient's a smoker, patient's got malignant hypertension, they're 200/120, you are going to roll with the Charcot hemorrhage. If the patient is not a smoker, but maybe they do have a history of AFib, or maybe they do have a history of a clotting disease, or maybe they have a history of atherosclerosis, then you're going to go instead with the lacunar infarct, which is ischemic and obstructive in nature rather than hemorrhagic. Here's another similar presentation, again, on the topic of strokes that occur in the lenticulostriate arteries. That's the topic that we're on right now, just to remind everybody. So recap, what are the lenticulostriates? Well, you've got two MCAs, right, that kind of go up bilaterally from the circle of Willis, and then they'll bifurcate, and you'll get a superior and an inferior branch of both MCAs, correct? But before they bifurcate, let's illustrate in green here how you have these perforating lenticulostriate arteries that are real thin, that pop up off of that M2 segment of the MCA to irrigate the basal ganglia, which includes the thalamus, the putamen, and the caudate nucleus. So this is where we're at. We're referring to strokes in these thin lenticulostriate arteries. And from there, we understand that those strokes can be ischemic in nature. We would call that a lacunar infarction, or they could be hemorrhagic in nature. We would call that usually a Charcot-Bouchard microaneurysm. The word micro is included there because these are, again, such thin arteries. So that's where we're at. Let's crack open a couple more practice questions. Here's a 65-year-old male with new onset headache that began 3 days ago. He's got a dull pain that will not go away. He's also had trouble walking and coordinating his upper limbs. So there are no sensory deficits here. Pure motor stroke. Thalamus and cerebellum, or I'm sorry, basal ganglia and cerebellum are interdifferential here. What else does he have going on with him? Vitals are pretty normal except for a blood pressure of 215/105. So you, the physician, suspect the patient may have developed a stroke secondary to this blood pressure of 215/105. And then the question is, the most likely location for a stroke in this patient would be blank. And so the basal ganglia, again, also known as your lenticulostriate arteries, and that's because these arteries are so thin, they're perforating arteries. And we look at the other answer choices and the brainstem. No, this doesn't fit a brainstem stroke. You know, you'd see a way different pattern of symptom involvement. You'd see cross signs and symptoms there. Frontal lobe, well, the frontal lobe does do motor function, but a frontal lobe headache would probably give you some. The frontal lobe does other things besides just pure motor. So you'd see other signs and symptoms besides just pure motor there. Occipital lobe, no, that does vision. Parietal lobe, no, not that either. That's not going to give you the motor symptoms. And so you're left with basal ganglia. Easy question. They just really want you to understand the location of these small, fine arteries. Here's a 78-year-old man presenting to the ED with involuntary movements of the right arm and leg. History reveals AFib, hypertension, DM, and a 40-year PAC history. Blood pressure is currently 185/96, and the patient's experiencing repetitive involuntary flinging movements. So when I see this, immediately I say, this is hemibolismus. This is probably a thalamic stroke that they're trying to guide me to. You look at the rest of the question stem, because great student always reads the whole question stem, because great student's a fast reader. So you read the whole question stem, you confirm there's no hemiparesis, no hemianesthesia, no language deficits, no visual field, normal eye movements. This is a pure motor stroke with hemibolismus. This is definitely in the thalamus. That question is occlusion of which artery is responsible for the flinging movements. And so then they give you ACA, ICA, basilar, pica, and PCA. And this question requires you to understand that the perforating branches to the thalamus come from the posterior cerebral artery. The anterior cerebral goes front, anterior, and then it goes up and back down the middle. So you're not getting anywhere near the thalamus with the ACA distribution. ICA and pica are both brainstem. Same with the basilar. That just gives off the ICA and pica, so you're left with the PCA. So this is the sort of question that they could hit you with given a presentation of a lenticulostriate stroke, which, one more time, going back to the big take-home points, lenticulostriate strokes can be ischemic, in which case we'd call it a lacunar infarct, or it could be hemorrhagic, in which case we would call it a Charcot microaneurysm. They're not the same thing. Keep them separated. The risk factors for the lacunar infarct are going to be AFib, clots, atherosclerosis. Risk factors for the microaneurysm is going to be smoking and hypertension. Back to the SDL. What you might see is the word microatheroma thrown around. And that's because we think these microatheromas are most important, numero uno, in causing lacunar strokes. And so microatheroma, it's a small fatty body, like atherosclerosis. So a microatheroma is just an embolization of a little bit of a atherosclerotic plaque. So if you have atherosclerosis, you're going to get an ischemic stroke, which is going to turn into a lacunar infarct. That's all that this is saying. And again, if you had mad hypertension and you were to pop a hole in a lenticulostriate artery, you'd see the same symptoms, pure motor hemiparesis or hemiplegia in the absence of cortical signs. You'd see the same symptoms in the same artery, but the mechanism there would be hemorrhagic rather than ischemic. I think you got that. Hypoxic-Ischemic Encephalopathy. big takeaway from here is, again, what parts of the brain are going to die first if you go globally hypoxic? So hypoxia is failure to deliver oxygen to a tissue. And remember, the most common cause of that is ischemia, which is a drop in arterial perfusion, which can be caused by an obstruction or by low blood volume. And then other causes of hypoxia, don't forget about hypoxemia. And that's usually due to respiratory problems or maybe something like carbon monoxide playing with your hemoglobin. So your brain, you could have totally perfect perfusion or blood delivery to brain tissues and still be ischemic. So again, that would be in the setting of something that's messing with the oxygen saturation of your blood or of hemoglobin or the oxygen content of your bloodstream. So that can also cause brain damage. And in the setting of one of those pathologies, remember, hippocampus is number one, particularly this area called Sommer's sector, which has large pyramidal cells, followed by the cerebral cortex, number two. If the hippocampus is not an option in this question, you're going to roll with the neocortex layers 3, 4, and 5. And then after that, the cerebellum, especially those large GABAergic output Purkinje cells, which receive inputs from the mossy and climbing fibers and are going to output via the superior peduncles. So again, what are the settings in which you see HIE, hypoxic-ischemic encephalopathy? Well, acute MIs, heart failure is high up on the list there. Your heart stops beating, you stop pushing blood up the carotids to your brain. And that's going to cause a global cerebral ischemia. So when you're thinking HIE, what sets this apart from every other topic in this SDL is that HIE is global. The whole brain is involved. It's not a focal thing. It's not a part of the brain. It's the whole brain sees a drop in perfusion. And so as a result, again, one more time, that hippocampus dies first, and then your neocortex, layers 3, 4, and 5 dies second. So that's your big takeaway here. And remember, when neurons start to die, they turn red. So you see red neurons. That's the very first microscopic change. I think you got that. Cortical laminar necrosis. How do you diagnose this? You see it usually, or they tell you with words what you see on an MRI. And what that's going to be is cortical curvilinear hyperintense lesions. And those lesions on the MRI correspond to extracellular edema and fluid collection, which is a result of cell death, cells spilling their ions, and so fluid pools in the area. And so that's tissue necrosis. Again, it'll turn liquefactive in the brain. It's cortical and curvilinear. So that lets you know that a particular region of the cortex is died off. Remember that the cortex of your brain, cortex is the outermost layer, it's structured itself in layers like a layer cake or like the layers of the earth, right? So you've got layer 1, 2, 3, 4, 5, 6 all stacked up on top of each other. And what this pathology is death of only one or two of those layers. And so when you look at it on MRI, you see a curved layer of tissue death in the cortex of the brain. And it'll look something like that, straight up. So layer 3 has the biggest, most oxygen-dependent cells, is therefore the most vulnerable to hypoxia. And one more time, this is called cortical laminar necrosis. And it's seen in the setting of a global perfusion deficit to the brain, or a global brain hypoxia. It's not a focal type thing. Border zones, you want to know border zones. They love to ask you questions about maybe what symptoms would this patient show, or what's the mechanism of this patient's findings. Let's talk about what the border zones are. They're areas of in-betweenness. So you've got an ACA territory and an MCA territory, and in between the ACA and MCA territory is this kind of shared community area that is both ACA and MCA, but really none of much either. And so if you get a global hypoperfusion of the brain, let's give an example. The patient gets in a motorcycle accident, they've lost a lot of blood. Well, then this watershed area will be one of the very first areas to see a drop in blood supply. That should be easy enough to understand. What are the watershed, or where are the watershed areas? Here they are. They're in the front and the back of the brain. These are called your cortical border zones, where the cortex can start seeing symptoms. Your ACA and MCA region is in the anterior part of the brain. The watershed between the MCA and the PCA is in the posterior part of the brain. And these are called wedge-shaped infarcts. Like a Dorito, like pick your flavor, like Cool Ranch, nacho cheese. I personally am a spicy sweet chili guy. The purple bag, I think that's the sickest chip ever invented. It's really nice. So it's a Dorito-shaped infarction in the front or the back of the brain, and you're going to see kind of mixed symptoms. It's a weird symptom pattern that doesn't fit any clear classification. And the mechanism, this is what you want to know, the mechanism is always a drop in blood supply to the brain. So maybe there's a common carotid stroke, maybe the common carotid has been sliced, maybe the patient's again lost a lot of blood, maybe their heart's not beating anymore and the brain loses perfusion. This is the pattern of infarction that you see first before you see infarctions in other areas of the brain. Now, there's an internal border zone as well, and it's cigar-shaped. And that would be right here, smack in the middle of the brain. You see it on that axial section. It's right there next to the lateral ventricles in the area of the basal ganglia. So this is where the MCA and the lenticular striate communicating arteries kind of, again, it's neither one or the other supplying this area. It's a little bit of both. And then if you lose blood supply, then it's just going to dry up like a desert right there on the internal cigar-shaped border zone. Again, what do they want to ask? What mechanism produced these findings? Understand it has to do with blood volume and thus perfusion. If you don't have enough volume to perfuse the brain, this is where you see tissue death first. And they're wedge-shaped and they're cigar-shaped. And it always, the underlying pathology is a loss of blood volume. Let's discuss glutamate excitotoxicity. The glutamatergic receptor is also called the NMDA receptor. And whenever that's activated, you're going to see sodium and calcium influx into cells. So you get ions inside cells. And then that's going to, if you've got way too much sodium and calcium inside a cell, bad things happen. First of all, that's going to draw water into the cell, cause some cellular swelling. Second of all, calcium does a lot of things inside the cell, and as a result, we like to keep calcium highly sequestered in cells. There's a reason why we store calcium inside the endoplasmic reticulum of cells. Think about the myocyte. We push calcium using a lot of ATP back into the sarcoplasmic reticulum whenever we're done with the muscle contraction. And the reason why we do that is we want to, again, very tightly regulate the concentration of calcium inside our cytoplasm. Reason being, calcium can activate lots of enzymes, and sometimes we don't want those enzymes activated. One of the things that calcium can do is that it can also provoke the release of cytochrome C from the mitochondria. Cytochrome C is a protein that's normally a contributor to your electron transport chain. If that gets out of the mitochondria, it then activates caspase pathways, which lead to apoptosis. Caspases 3, 8, 9, those sorts of things. And so too much calcium leads to cell death. Hence, glutamatergic mediated excitotoxicity. It's a calcium thing. If you have too much glutamate signaling, then neurons start to die. There are a few drugs that can do this. And this is also a pattern at the physiologic level that's seen in a couple of pathologies that I believe will come up again in the Alzheimer's SDL. And that's it for this first discussion on cerebrovascular disease. Let's crack into number 2. Whereas the first SDL was about ischemia, the ischemic mechanism of damage, again, being usually obstructions or shock, this SDL tends to focus on the hemorrhagic strokes. And again, number one predisposing factor to a hemorrhagic stroke is going to be high blood pressure. How do you get high blood pressure? Well, endothelial damage contributes to that. So smoking causes you to lose your ability to vasoregulate, vasomodulate, and dilate and constrict according to your needs. So with smoking, you get some endothelial stiffness and damage that can predispose you to hemorrhage. Also, just high salt in diet, high dietary salt and fluid intake, that can just raise your blood volume, ramp it up high, and that'll leave you, if uncontrolled, you can get up to 180, 190 systolic like that too. And so uncontrolled hypertension is the big risk factor for hemorrhagic strokes. Subarachnoid hemorrhages, I think those are at the end. I won't talk about that yet. So hypertensive intracerebral hemorrhage, if they tell you in the name, big risk factor is hypertension. They will tell you that the patient has hypertension if they want you to pick the hypertensive hemorrhagic stroke as the answer choice. The lenticulostriate arteries that supply the putamen, the caudate, the thalamus, the basal ganglia, those are usually the first to get hypertensive hemorrhages in them because they have the thinnest walls. You see this pattern called arteriohyalinosis or hyaline arteriolosclerosis. And then you can also see what's called hyperplastic arteriolosclerosis. I really recommend that you look those terms up. I'm not going to go into them right now. They're very relevant in block 4. And understand that whenever you see hyaline change in an artery, that what you're looking at, it's going to be pink, pink, pink on histology, and you're going to be looking at collagen deposited around the wall of a small artery or a capillary. And so collagen is a problem for an artery because oxygen diffuses directly through the endothelial lining of any capillary to get into the surrounding tissues. And so if there's collagen lining a capillary bed, that creates a greater diffusion distance for oxygen to have to overcome before it can get into tissues. And so this kind of scarring up of the artery is going to lead to tissue ischemia. It's also going to weaken that artery. Again, it's inflexible, it's stiff, it's rigid, and thus more prone to rupture in the setting of a hypertensive episode. And so that rupture, because of the scarring up of the artery, is what gives you these Charcot-Bouchard microaneurysms in the lenticulostriate arteries. So one more time, this is not a lacunar infarct, but this can lead to a lacunar infarct because an infarct is tissue death. And so you can approach the infarction, you can get there from ischemia, or you can get there from hemorrhage, right? And so a hemorrhage, again, is different from an ischemia because an ischemia is an obstruction and a hemorrhage is just, it's an arterial wall problem. It's a mechanical thing. It's really mechanical. So if it's hemorrhagic, we call it the Charcot-Bouchard microaneurysm. It can get pretty big, usually going to be red and not pale on a gross section. So if you see red, you're thinking hemorrhagic. The next thing you ought to think should be smoking and hypertension versus, again, the pale infarction. Let's take one more look at that. You see a pale infarction like you do on the left side of the screen here, you need to be thinking atherosclerosis, AFib, obstructive pathologies. The putamen is the most common site for hypertensive hemorrhage. That's really important. Why? Because you tend to see pure motor signs when the putamen is involved. You don't see any sensory deficits, and it's going to be contralateral to the sign of the damage. And the facial sag, that's motor, right? You know, you need motor to talk to, so speech will slur, maybe vision will blur because you need motor to focus your eyes and move your eyes. And so it's going to be motor, 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 this and that, no sensory anything. That's how you get a clue that the putamen is involved. Let's discuss cerebral amyloid angiopathy. Understand that amyloid is a motif or a pattern of folding, and folding is important because amyloid is kind of a verb. You know, I know that doesn't make intuitive sense what I said. Let me break apart the first aid page for this and show you how amyloid as a disease is categorized, because that'll help you get a clue for what it is. So when we're talking about amyloidosis, that's the state of having a lot of amyloid in the blood or the body. Osis, amyloid. So look and see how there are different types of amyloid protein. That's the first thing you want to notice. There's amyloid light chain. And I'm going to plug my computer in real quick because I'm about to die. But there's amyloid light chain, you know, there's amyloid A, there's beta amyloid, there's islet amyloid polypeptide, there's that light chain amyloid again. So there's all these different types of amyloid. So what that means is that different proteins can misfold and give you amyloid, right? So if calcitonin misfolds, it'll give you amyloid. And then if ANP, atrial natriuretic peptide. If that misfolds, that can give you amyloid 2. Maybe it's transthyretin that has to do with the thyroid. Maybe that misfolds and gives you amyloid. So the concept here is that there's a normal protein that gets all bent out of shape. You know, it suffers a orthopedic type of injury. It's all bent over now. And so this protein's misfolded. And so what that means is that it just sticks around in the cell and accumulates. You can't do anything with it. You can't ubiquinate it, so you can't shred it up in the proteasome. You can't get rid of it. It just sits around and pulls water into the cell because protein has an oncotic pressure. It contributes to the oncotic pressure of a compartment. So the protein sitting around in the cell doing nothing, pulls water in the cell, causes a osmotic stress on that cell, eventually kills it. That's the mechanism of cell death and an amyloidosis. So lots of different proteins can misfold to give you amyloidosis. And so the reason why I said it's kind of a verb is because even though there are all these different nouns, there are all these different proteins involved in amyloid, they all undergo the same verb, which is misfolding. No matter what you're talking about, the common theme here is that there are proteins misfolding to give you amyloid. And amyloid is just a name for misfolded protein. So a lot of different precursor proteins, a lot of different types of amyloid. What they all have in common is the verb. They're misfolded proteins. And then something else that they all have in common is that they are going to stain for Congo red. And this Congo red stain upper right corner here is going to be apple green birefringent under plain polarized light. They'll almost always tell you that if you're looking at some amyloid histology. So many different organ systems can be involved in amyloid. And in this particular SDL, we discuss amyloidosis of the brain. So now that we understand what amyloid is and what an amyloidosis is, let's look at its effects in the brain. When soluble proteins adopt a beta-pleated configuration, they become insoluble and prone to oligomerization, fibrillization, and deposition in target organs and tissues. This disrupts their normal function. Therefore, you get amyloid deposits in the brain. That part of the brain stops working. That's the mechanism for dementia and Alzheimer's. So this particular cerebral amyloid angiopathy has two forms, sporadic and inherited. And both of these forms are going to involve amyloid beta. So we said that there are different forms of amyloid. Well, amyloid beta is the one involved in the brain. So that's easy. Beta, brain. You're not going to forget that. And then what you want to understand is that amyloid precursor protein, also known as APP, is the name for the protein that misfolds to become amyloid beta. So you got the names, you got the gist of the pathology. It's going to be easy to recognize this. It stains Congo red and it turns apple green under plain polarized light. In the brain, endothelium is what gets hit first by amyloid. It's a vascular disease mainly. It's not going to be too much of a functional disease because that would be Alzheimer's. But this is an amyloid angiopathy, angio, blood. So this is a blood vessel amyloid problem, not a neuronal amyloid problem. That would be Alzheimer's. So in the setting of CAA, your blood vessels are getting filled with insoluble amyloid misfolded protein. That's what's going on. And then your blood vessels get injured. They lose their ability to stretch and vasomodulate. And so then you end up having hypoperfusion or tissue ischemia to various affected areas of brain. Last thing I want to say about this is that apolipoprotein E greatly influences this disease. What is an apolipoprotein? Well, recall that fat and water don't mix. And fat is hydrophobic. And some lipids are polar or amphipathic, meaning they swing both ways. And so they're going to have a polar head and a non-polar tail. And anything non-polar doesn't mix with polar water. So the reason why we make amphipathic lipids is to package them inside spherical shapes and conformations with the polar side of the lipid or the head group of that lipid lining the outside of the sphere. and the nonpolar part of the lipid, or the tail of that lipid, oriented inwards towards the center of that sphere. And the reason why we do this again in our body is because lipid is not water soluble. So if you want to move lipids around in fluid blood, you have to flip them and package them so that they are lined by a polar covering that will enable them to move and traffic inside the bloodstream. And so when you do that, you put proteins on these lipid spheres to hold them together and make sure they don't spontaneously dissolve, anytime they bump up against the wall of the blood vessel. And so apolipoprotein E is an example of one of these carrier proteins that shields a lipid sphere while it's traveling in the bloodstream to kind of give it some crash resistance so that it doesn't again spontaneously decompensate. And that these apolipoproteins are also signaling molecules that can dock a sphere of lipids into cell surface receptors on any target tissues and then trigger the delivery of lipids into whatever cell it's docked into. So apolipoproteins are very important, and they're all throughout the bloodstream at any point in time. There's a ton of apolipoproteins in the blood. So what you need to know about this apolipoprotein E is that there's a couple of variants. There's an epsilon 2, an epsilon 3, and an epsilon 4. And in fact, if you have the epsilon 2 or epsilon 4 allele of the ApoE protein, then you are at an increased risk of cerebral amyloid angiopathy. Now, listen to this. We said CAA is not Alzheimer's, right? Because cerebral amyloid angiopathy is amyloid inside endothelial cells lining blood vessels. Now, Alzheimer's is amyloid inside neurons. So, two completely different cell types affected by these two similarly amyloidotic diseases. Now, E2 is going to predispose you to cerebral amyloid angiopathy. It'll increase your risk of this, but the E2 allele of apolipoprotein E is actually protective against Alzheimer's disease, meaning if you have E2, you are at a higher risk to get amyloid in your endothelial vasculature, but you are at a lower risk to get amyloid inside your neurons. So two amyloid diseases, E2 is going to do one thing in one thing in the other. Now, E4, this E4 allele, it's cool because it just predisposes you to both amyloid conditions. But again, make a little note of that, set that apart right now. ApoE epsilon 2 allele is protective against Alzheimer's. It lowers your risk of getting Alzheimer's, although it raises your risk of getting this amyloid angiopathy. And that's straight up, I think, all you have to know about amyloidosis for the brain at this point in time. Rare causes of intracerebral hemorrhage. Understand a vasculitis. Itis means inflammation. So anytime there's an inflammation, there's an immune system response. Whatever's before the itis tells you where it is. So in this setting, or in this pathology, there's an immune response against cells lining your vasculature. That's a vasculitis. It's just inflammation of the walls of blood vessels. And typically you get neutrophils all up inside the walls of blood vessels. And this is most commonly due to type 3 hypersensitivities, which is your immune complex type. And remember that immune complexes are just an antigen bound to an antibody, and that these are sometimes insoluble in blood. And so if it's insoluble in blood, then it's going to be predisposed to stick in the walls of arteries because, right, it's crystallized, it's not soluble. And so if it deposits inside the wall of an artery, an immune complex does, well, guess what? Antigens and antibodies are chemotactic for the immune system. And so neutrophils swarm to spots lining the vasculature that are just packed with immune complexes, and you get neutrophils eating these immune complexes and then activating themselves and degranulating. And guess what neutrophils contain? Basically a whole bunch of like toxic nuclear grade acid. And so neutrophils degranulate and they spill their acid contents all over the walls of your blood vessel, and that farther messes stuff up. You can tell what I wanted to say there. And so that's a vasculitis. You got a neutrophil response to immune complexes. The neutrophils go bleh, and they breathe fire on everything like Godzilla, and that hurts every small blood vessel in the area. And so how does this present? Well, you typically get little petechiae. You get little pinpoint red hemorrhagic areas because those are areas where immune complexes are getting stuck and neutrophils are killing everything. And so a petechial rash is a typical sign of a peripheral vasculitis. Bleeding disorders, maybe if you're just totally anticoagulated, you know, to the moon, you're on warfarin and you got an INR of like 5 or something, you know, it's like you're never going to clot, you know, it's like we're going to be waiting for you to clot next month. Same thing with heparin. So it's like someone who is anticoagulated to the moon and back is going to have a higher risk of an intracerebral hemorrhage, especially if they're hypertensive at the same time. Drug abuse, cocaine and meth. Well, what are those? Those are adrenergic agonists. What does that do? Those vasoconstrict. You got an alpha-1 receptor that vasoconstricts. So if you got a lot of blood volume, but your small arteries and capillaries won't relax, you know, then putting that high blood volume, that high blood pressure through them can predispose them to rupture. Venous thrombosis, yeah, because that's going to cause a buildup of pressure behind the obstruction that can lead to a hemorrhage. I hope that makes sense to you. Again, hemorrhagic infarctions, they're red. What's our risk factor? Hypertension, smoking, and then these rare causes here. You contrast that with the pale infarction, which you're going to see a question about at some point in time. And again, those are due to obstructions, clots, fatty plaques. Here is a concept I want you to understand. Hemorrhagic transformation. What does that mean? That means that sometimes, every now and then, you start off, patient gets a pale infarction, but then a day or so later, if you were to look at the brain, it would be a red infarction. So the pale infarction transforms into a red infarction, like Optimus Prime, okay? It was a truck, now it's a robot. Like that's how this thing transforms into a red infarction. And how it does this is laid out in the SDL. A hemorrhagic infarct is an ischemic infarct that undergoes hemorrhagic transformation. That's not necessarily true. Sometimes you straight up skip the ischemic stage, you go straight to the hemorrhagic stage. Okay, so like if you get a Barry aneurysm, there ain't no ischemic stage there. You are right immediately into hemorrhagic territory. So if it's red, you're bleeding into the tissue. Over half of all cerebral infarcts at some stage develop some hemorrhagic component. And the hallmark of the hemorrhagic transformation is the petechial hemorrhage. What are these petechial hemorrhages? Let me try to ELI 5 and then we'll go back to the SDL. You get a clot in a part of the brain. Everything downstream from that clot goes ischemic and turns pale. Next, you bust the clot. You give TPA or something like that, a fibrinolytic. You get the clot out of there. The patient's still alive. Therefore, everything that was downstream of the clot that didn't have any blood going to it now has a lot of blood going back to it. That's called reperfusion. Okay? So when you reperfuse the brain, you send blood back into a territory that was dry, that was bloodless for a given amount of time. When you do this, blood gets in there and gives you these petechial appearances on a gross section. So one more time, the concept is you get a clot, everything past the clot dries up, you bust the clot, you put some blood in it again, you see these petechia. That's the simplified version. And the big word here is petechial. They want you to know petechial corresponds with this reperfusion injury. or this pale to hemorrhagic transformation. So hemorrhagic transformation might be spontaneous, or it could be after you bust the clot. It could be spontaneous because your body's got some built-in thrombolytic proteins that remodel clots if they're not supposed to be there. That's called hemostasis, which is the balance of components in your blood, pro versus anticoagulants. Hemorrhagic transformation results from reperfusion of the vascular bed of the infarct after relief of the occlusion, such as would occur after fragmentation of an embolus or from collateral vessels into the necrotic area. Here is an example of a petechial histology that's got kind of a dot-like conformation. It's like it's been sprinkled with some drops. You know, that's what petechia are. They're just tiny little circles. Pinpoint hemorrhages. So understand that concept, because they like to give you the petechial hemorrhage and say, what was the mechanism for this? This is exactly how this question gets asked on boards, across question banks. They show you the petechial red infarct, and the questions, what was the mechanism for this? And A is going to be something like straight up hemorrhagic stroke. Okay. And then B is going to be something like thromboembolism. And so you might be thinking, oh, this is a red infarction. It had to be hemorrhagic, but no. Because of this reperfusion phenomenon, this transformative phenomenon, the mechanism of the stroke was thromboembolism, but it turned into a red infarct. So that's how the question gets asked, and you're going to get it right now. Subarachnoid hemorrhage, I don't have a ton to say. I know that you're going to study this on your own because it's a very important pathology. And what I want to point out is that there is a clear difference between a saccular and a fusiform aneurysm. And you will see this again in AAA's abdominal aortic aneurysms. And so you want to recognize grossly that a saccular aneurysm is asymmetric. It's only bulging out of one side of the affected artery versus a fusiform aneurysm, which is pretty symmetric. You know, it's going to be a outpouching of 360 degrees of arterial coverage there. So big difference between saccular and fusiform, know it. Understand the ASA, anterior communicating ACA is going to be the number one spot where you get subarachnoid hemorrhages, baryaneurysms, and you're also going to see them at the junction of the common carotid and the middle cerebral artery. That's your number 2 spot right there. How do these present? Remember that you've got that kind of Death Star appearance on a non-contrast CT. You always get a non-contrast CT. Here's something about Ehlers-Danlos syndrome. Recall that you've got hyperelasticity of the skin and joint hypermobility in Ehlers-Danlos, and the type that gives you the baryaneurysms and the subarachnoid hemorrhages is going to be the type with the collagen 3A1 mutation. That's going to be type 4 Ehlers-Danlos. And typically what's on the differential is going to be like Marfan's, you know, because that predisposes you to aortic pathologies, but not to subarachnoids. And then something like OI might be on there too. So they'll give you a bunch of connective tissue diseases. You'll have to pick out Ehlers-Danlos, or maybe they'll give you the various subtypes of Ehlers-Danlos, like super rare. They would never do this, but maybe, you know. And then you'd have to pick out that it's the one with the type 3 collagen involved. Subarachnoids, again, characteristic location. You do a non-contrast CT. If you still suspect the subarachnoid, but the non-contrast is negative, you want to do an LP, and you're looking for this, I think it's called xanthochromia, is the presence of red cells inside the otherwise clear spinal fluid, giving it a yellow or even sometimes a pink-orange color. And so that finding of blood in the CSF would be diagnostic for a subarachnoid in absence of a positive CT finding. And now we talk about vascular malformations. Put simply, there are 2 of these that you should really care about because they're a lot more common. And then there are 2 of these that are a lot less common, and they would have to basically give you the diagnosis in the stem of the question. If they wanted to test you on, for example, the capillary telangiectasia, they would have to say there are telangiectasias inside capillaries in the brain. And if you know what a telangiectasia is, then it's like, thank you for the free question. Same thing with the venous angioma. They would have to tell you, hey, it's only the veins of the brain that are involved here, not the arteries. And so that would again lead you to say, oh, this is the venous pathology. Thank you very much for the free points. Now, the two that you have to tell apart, because they like to give you photos of this grossly, or they like to show you histology of this, the two you want to tell apart are the cavernous hemangioma versus the AVM. So the AVM is like a knot. Think back to when you were 5 and you got your first shoes with shoelaces, right? And you're like, yes, like I'm out of the Velcro leagues now. I'm a big league boy. And so it's like, I'm going to tie my shoes. Yes, I am. So you sit down to tie your shoes. You tie them for the first time. And what do? Man, you put the biggest knot in them. You tie them so tight, you tie it maybe like 5 times. And then it's like, sure enough, you go take your shoe off. You can't take your shoe off because you're a rookie and you just over tied your shoe. And so now you're sitting there crying because you're trying to get your shoe off your foot. You gotta get your mom to undo this knot and take the shoe off for you. So that's an AVM. It's a big knot that you can't undo. Versus a cavernous hemangioma. It is exactly what it sounds like. It's a cavern. So a cavern is just going to be essentially a tunnel, but wider, right? It's like, I feel like everyone wants a cavernous home. Nobody wants a tunnel of a home, you want a big, wide, open space. And so a cavern is going to be like, caverns are cool, man. You ever been in a cavern? Then they got like waterfalls and stuff. Be like, walk and see some cave paintings, yo, and like Ruby Falls. That's what I remember. Yeah, that's in Tennessee, yo. Kentucky's got some caves too. They got Mammoth Cave in Kentucky. But you're looking at this histology and it's a cavernous hemangioma. I mean, like, look at this thing. Do you see any blood vessels in here? No. So it's not an AVM, right? And then you look at the AVM grossly and it's like, you can see why I call it a knot. It looks like you took a ball of yarn and just cut it in half and then looked at it, So it's like the AVM grossly looks so different compared to the cavernous hemangioma. One's got a lot of blood vessels that you see. The other is just one obliterated space. And the histology is pretty similar there too. Again, you're seeing this, you're like, wow, those are some cavernous spaces. And then you go back up and look at the AVM and you can see that there are a mixture of arteries and veins here, which is why it's worthy of the name arteriovenous malformation, because it involves both arteries and veins. And so in words, what these pictures show you are, for the AVM, dilated and tortuous vessels. They really that's basically what they will tell you if they don't show you a picture. And then for the cavernous hemangioma, large, cystically dilated, thin-walled vessels. That's very important to know. Again, dilated, thin-walled, it's a vein type thing. And that's about all that you have to know for the cavernous versus the AVM. Be able to tell those two apart from one another, and I'm sure that you will be very happy come test day. So that's all that I have to say about strokes and cerebrovascular disease. Thank you very much.